Hospital in Harlow in Essex. We work for the quality improvement team, which is called Quality First, and I'm the senior nurse, the associate director of nursing for the team. Robbie?
And hello, my name is Robbie and I'm the Deputy Director of Quality Improvement at the Princes Alexandra Hospital. We'll do so if we can. We've got some slides to just help structure the session and talk us through what we're going to cover this morning. But before we do that, let's do a round of introductions. Just if people can say their name, hello, my name is, and then where you're from and what your role is, to give us some kind of idea of who we've got in. And as Vandra has already outlined, we want mass crowd participation during this session. So please, please, please get involved. So Vandra, do you want to go first and introduce yourself?
Yes, by all means. My name's Vanda Carter. I'm a nurse researcher and educator from the Wolverhampton NHS Trust, and I'm the facilitator as well for today's session.
Excellent. Darren?
Yeah, my name's Darren Farmer. I'm from the Royal Wolverhampton Hospital. I'm a new health visiting team leader within the Trust, so I've come along to this today.
Excellent. Thank you. Claire?
Yeah, my name's Claire Flatt and I am the lead for nursing midwifery and AHP leadership development at the Royal Wolverhampton Trust as well, and I'm also today's facilitator.
Excellent, thank you. Julie from Oxford.
Oh, hi. I won't put my camera on because I'm on annual leave and I'm in relaxing wear.
Yeah.
That's my little self-care thing.
Yeah.
My name's Julie Fuller. I'm a senior matron in older adult mental health down in Oxford.
Welcome.
Welcome. And we've got, I'm going to pronounce this wrong because it's a double F. From Somerset CCG, someone Griffiths?
It's Fionn.
Fionn, thank you and apologies.
That's okay. I'm a management trainee, but also workforce programme lead at Somerset Integrated Care System.
Excellent. We're a big fan of graduate trainees in our team because we always have one or two with us, so welcome. And the lady that needs no introduction, I give you Rachel.
Hi everybody.
No introduction. Could you introduce yourself, please?
Hi everybody, my name is Rachel and I'm the social media manager for Fab. So all the tweets have been scheduled from me. So I'll be filling up your Twitter feeds and I'm just sort of popping in and out of the tents.
Excellent, thank you. And Ruth?
Morning everybody. My name's Ruth Stokes. I'm Senior Sister in Nursing Quality at the Royal Wolverhampton Trust.
Excellent. And the final person we've got on here, I don't have your name on the list, it's just 10 to 3.
Hi, my name is Gabby. I work in live events and I'm just here to help Vanda and Claire out with techie stuff and anything else you might need. I'm not called Temp 3, unfortunately.
And from PAH, we've also got Nicola.
Hello, my name's Nicola Tickersing. I'm the lead nurse for mortality at the Princes Alexandra Hospital. And I am joining today, but I do need to leave at 9:30 because I've got another presentation to do, but I will jump back on. So I'm looking forward to today.
Thank you so much, Nicola. And we've just had Terry join us. Hello, Terry.
Me turn my camera on. Hello, the absolutely fabulous Princess Alexandra Hospital. I couldn't miss it if great to be here.
Wonderful to have you here. Introductory slides just to further kind of introduce ourselves and set the scene a little bit, and then we'll talk about action learning sets and how we're going to work together this morning. So we've done a welcome, and can you all see the slides okay? Excellent. So this is, for those that don't know, if you see the blue map of the UK on the right-hand side, you're going to see a pin drop. And that pin, that red pin, is where Lindsay, myself, and Nicola are based as a hospital, so the Princes Alexandra Hospital. We are a small district general hospital, but when I say small, we still have well over 100,000 patients come through the doors of the emergency department every year. But that's where we're based in Harlow. And to give you some key numbers, to give you some context of the hospital where we work, so it is 414 beds, quite a lot of outpatient appointments, as you can see, 109,000 ED attendances, nearly 4,000 babies delivered at the hospital every year. We had a documentary with Emma Thomas.
Emma Willis.
Emma Willis, thank you very much, Lindsay. I don't know who Emma Thomas is, but there we go. Emma Willis with us. Was it called Delivering Babies?
Yes, I know.
Well, there we go. That made us slightly famous for a little while. And then we had, that's how many non-elective and elective admissions that we have, and total number of nursing and midwives, income, and our surplus position. You can see, to give you a flavour, a taste, an overview of the Princes Alexandra Hospital. That's where we're based. And we're super mega proud because Lindsay and I work for the Quality First team, and our Quality First team were really launched, brought to life, began our time in terms of as a team back in 2017, and we launched our team and our focus, all the rest of it, alongside the first time the hospital really got involved with Fab Change. And that year, for those who were there, it was amazing in the O2, and we've had an amazing time and amazing support from the Academy of Fabulous Stuff. But the trust here has won Champion Trust for a couple of years, principally because of the quantity and quality of sort of pledges and quality improvement achieved in the hospital and service improvements and the shares, etc. The team absolutely embraced the ethos of the Academy of Fab Stuff. And this year, these last 18 months, Terry and I were messaging, have been tough for everyone, and I think it's knocked us all, whether it's personally and organisationally, for six a little. And we want to get back on track with everything Fab, hence why we wanted to be a part of things today. But our team are here to inspire our people, and when we say our people, we don't just talk about the people in the hospital. We work as a health and care system, like many of us. And our training and learning and development is conducted with partners as well as hospital colleagues. So inspire our people to put quality first for the benefit of patients, staff and wider community, to build confidence and capability in quality improvement. That's why we exist. That's why Lindsay and I come to work. And one of our improvement partners is Nicola, who's on the line today from PAH. And yeah, that's us in a nutshell. So this is why you're here today. We're really keen we run action learning sets fairly regularly. We run, with Lindsay and I are supporting Band 7 nurse development and all sorts of other bits and pieces where we run action learning sets. And so the topic of conversation today is in the context of working to improve care, improve services, a lot of what Fab is all about. We would like you to share your bumps in the road. So if there's things that you've struggled with, it could be in your current role, previous roles, that type of stuff, examples where you've struggled or struggling to overcome something. So together we're going to work through how we can overcome those bumps in the roads, recover from those bumps in the roads, and also learn from those bumps in the road. So that I think, did we have a hand up or something in the chat? No.
The next one.
Okay, no worries. And just for context, for those of you, has anyone on this group outside of PAH colleagues been involved with an action learning set before? Have you all participated in something similar? I'm seeing a few nods. Yes, wonderful. Yeah. Excellent, so you're all pros, which is great. But the focus for it is we want the end result to be real action and real change in terms of the outcomes that come from our learning together. And we all want to be mentors, support each other in addressing the question. And we expect there to be questions. We want to seek answered. There'll be high support and challenge in the discussion, but we're obviously going to be kind to each other. and we're going to be positive, open-minded about the issues and problems being discussed. And if we can, please, so it's being shared, it's being recorded, etc. So have that in mind when you're sharing. So in terms, but when it comes to the confidentiality point at the end, so be mindful of that. But please feel free to share as far as Lindsay and I are concerned, because we will. And so, as I say, we want the end result to be things that can actually help you move forwards, overcome and learn from the bumps in the road that you may have experienced or experiencing.
So what we'd like to do, and obviously we're testing this out on you because doing it via Teams is very different to doing it in a face-to-face. But what we'd like you to do is to have volunteers from those of you who are present here today to share a story or experience of when you've been on a journey of delivering change for patients, staff, across within your own organisation or within your team, but you've hit a bump in the road, something that, you know, sometimes knocks our resilience, barriers to change, and we'd like to use that story to help use action learning to overcome, recover and learn. So if anyone, I mean, we've said raise hands because we, you know, obviously weren't sure how many people would attend, but very happy for people just to speak up, to identify someone who's willing to share a story. Quite a small group today, but so I think, you know, we'll see how we go. But I think we'd be able to take up to at least 3 stories in the time we've got allotted. But certainly, is there anybody who, and I appreciate Nicola, you've got to go, so you might not want to go up first, but is there anybody else who would like to share a story and discuss their bump in the road?
That takes a little bit of courage, but you're amongst friends. So who's that? Someone's got Ruth. So if we go into the next slide, Robbie, thank you. So how we're going to do this is to use the normal GROW coaching model to do our action learning today. So Ruth, once you're happy and once everybody's ready, we'd like you just to give a little bit of background and context to your change or your improvement journey, whatever you want to discuss. And then we'll ask you to pause. And then what we're going to do is ask the group, and again, because there's not a lot of us, you can either put your questions in the chat box, or we can, you can just interrupt if there's no one else speaking, just to ask some reality questions. So that gives the opportunity to ask questions, just to explore a little bit more. But what I'd encourage you to do is use very open questions rather than closed questions, to try and get a little bit more depth to what the real challenge was for this individual. And then we will obviously we'll ask the presenter to expand once they've had the questions asked. Once we've got to the deep reality and there's no more questions to ask, we'll all ask you all to deliver potential solutions. You know, what would you do in that situation? What have you done in the past? What else would you suggest? And I'm going to ask the presenter at that time maybe to just listen, not, because sometimes the first reaction is to jump in, but I've tried that, no, so just try and listen to all the suggestions, and then we'll give you the opportunity at the end to say, actually, what resonated with you the most? What are you going to take away from this session, and what will you do next? Okay, so I've got a few hands up. Is that volunteers, or so Robert, do you mind telling me who's speaking? So Ruth, is that the original hand to say yes, you want to go first, which is great, excellent. And Nicola?
Yes, I have a topic I'd like to discuss as well, please.
So hopefully when you come back, you'll be able to, we'll have finished one and you'll be able to share. Thank you. Anybody else? So we've got Ruth and then Nicola. Any more hands, Robbie?
Should we see how it goes with Ruth, and then if anyone else wants to come forward, that'd be great.
Okay, and as I say, please put your questions. One of us will keep an eye on the chat box, so please keep your either put your questions. Oh, I've lost everything. Put your questions in the chat box, or just raise your hand so that we can look out for you. So Ruth, when you're ready, do you want to give us a brief description of what you were trying to achieve and what the bump in the road was?
Thank you. So it's quite generic, but I'll apply it to sort of one of my work streams. So I've been a ward manager in the trust for the last 3 years, and I've been working within the quality team now since March. So my biggest work stream is around nutrition. and we've launched a strategy, etc., you know, a trust strategy for that, and done an update. So this, as you can imagine, nutrition is a big subject. So we've identified a nutrition pilot ward, or a pilot ward for nutrition, and we've looked at sort of priorities. And one of the priorities I'd like to look at is around improving our compliance with weighing patients, you know, not just from a nutritional aspect, but obviously with weights as well. It impacts on medication dosage. So my biggest barrier, and it's very difficult because I'm sort of fresh off the wards as well, it's about, I get the engagement with the teams, and you know, and that's brilliant, but then I also understand their sort of clinical pressures and demand. So what I see is the initial engagement is there, but it peters out quite quickly because of staffing issues and because of their clinical demand, really. And I think the will is there. It's very frustrating because while I know it's difficult, isn't it? Because you want to go in and you want to do it yourself, but the whole idea of quality is to sort of, you know, work with the team and support them to do the change. And I know the will's there, and I know the engagement is there, but it's being realistic and offsetting that against the clinical demand and the staffing pressures and winter pressures already, but also trying to get those little bits of change implemented. So that's my biggest sort of, not frustration, because I am realistic about it, but sort of it's hard because you don't see that sort of little change that you know is quite a quick win. So that's my biggest barrier, I would say.
Thank you. So what we'll do now is we'll ask the group to explore a little bit deeper, and if you don't mind, we'll also ask you questions, just to get a little bit more depth to understand. So has anybody got a question for Ruth?
I think from my perspective, Ruth, it's something that we can probably all relate to. I mean, it's a very relatable topic that you brought up in terms of how do we release capacity for change. So my sort of question, my clarifying question is, so what's the specific, so what do you measurably want to change and deliver as a result of the changes you want to introduce?
I mean, there's loads that I'm doing. You know, I'm looking at meal service, I'm looking at drinking cups for patients. There's lots of stuff in there, but because we've generally, you know, across the trust, we know that we should be weighing patients on admission, for example, and it's a real basic. So on the ward, this pilot ward, we're looking at doing little changes, you know, around communication with the staff, or raising awareness, or putting little interventions in that can hopefully improve our weight compliance, so that we're weighing our patients, so that, you know, ultimately they're getting better outcomes, and that we're identifying risk of, you know, malnutrition, stuff like that. And so it's just a, you know, we focused on weights first because I've noticed someone's put in the chat, why focus on weight first, and this is what I discussed with ward manager on the ward, and because obviously I'm conscious as well, it's not my ward, it's her ward and the team's ward, and the practice education facilitator was there as well at the meeting, and I said, what would you like to focus on first? And we said that weights really being a basic, there's lots of other things we've got planned. So the will is there and the engagement's there 100%, I know that, but it's so hard to see them torn between agendas.
Okay, so Darren's also, thank you, and Darren's asked a question, how often would you like to weigh patients? So what's your goal?
Yeah, so we should be weighing on admission to the trust as a baseline, and then ideally, you know, best practice would be that on admission or transfer to another area. But as a start, we're saying, you know, within 24 hours of admission to the trust, and then weekly.
Okay. And how are you knowing what your current compliance is? How do you know how well you're doing at the moment?
So we use Vitals Clinical in the trust, And I've done 2 scopes over the last few months around that. So as a baseline scope to see what trust compliance was. And most ward areas are on vitals. And then I did a second one, and after sort of doing a few things along the way to raise awareness. And currently it's about, I think, 24% of patients on that scope, but obviously it's a snapshot. It's a snapshot, that scope.
And how have you used that information to engage with the rest of the team?
Well, obviously it's not about naming and shaming, is it? And you know, I think there's validity in sort of, as a ward manager, I always like to see what other wards were doing, because you always compare, don't you? And, you know, sometimes it brings out that little competitive edge in you in a healthy way. But it's just about, I mean, the ward areas, good ward managers, they already know what the issues are, don't they? You know, and they want to change them, you find. It's just, I think they struggle as well because the will's there, but you know yourself, they come on a shift, and if they're a nurse down or a staff member down, then that has that impact on that change.
I heard you say earlier, sorry, I'm asking questions, so please everyone else do either put it in the chat box. I heard you say earlier, obviously you've got the engagement to start with and then it wasn't sustained. What was the difference? What did you see change? So
obviously I've been doing lots of stuff around this these agendas in the trust anyway. So I'd met with Sister a while back, you know, and then we did another meeting, and we got a specific sort of, just a little win really, just to try for a month or so. And initially, so it's very basic, but because I'm vitals, I can see how many nutritional screenings are due, how many weights, etc. You know, initially we started with 4 on a 21 bedded ward. And in my mind, you know, as quality, I thought, oh, you know, tomorrow there'll be 3 and the next day there'll be, and I've noticed as the week has gone on, they've become more. So say, for example, yesterday we've got 9. Yeah. And it's very easy, isn't it, for me to sit in the quality office and think, well, why haven't they? But it's not about that, is it? So it's just, for me, it's about balancing that clinical. I know the will is there. But it's very difficult for them, isn't it?
I'm going to put a real challenging question to you. How do you know the will is there?
Because I know, you know, I know that definitely from a leadership point of view, that the ward manager is very much about the patients, you know, and very much about improving the care for patients. So I know the will's there. But it's just, I think they're just really pulled from a clinical point of view. It's very difficult for them. And for me, it's about finding that balance, but not doing it myself.
Thank you. And Claire's asked a very pertinent question. She's actually, but is there a lead on the ward RN to support you? But who else have you got to support you? Because you said the ward manager. Who else have you engaged with?
And obviously I've had conversations with the staff, and there's a really proactive ward assistant on there. So, you know, like the ward hostess, because that's a really important role with nutrition. And I think, you know, they're very engaged initially, but then it doesn't get sustained. So yeah, I've spoken to other people.
So it sounds like to me the bump in the road is the non-sustainability.
Yes.
Yeah. And Vanda's put a question in the chat box. What is your understanding of the team's knowledge and understanding of quality improvement?
I think they understand it, as I did as a ward manager, but I think we see the other side to it, don't we? Because we use the tools, etc. So I think, yeah, I think we come at it from different angles, don't we? But then also I'm conscious that, you know, this is my main focus and they've got lots of agendas on a ward.
So anybody else got any other questions to get more in depth into Ruth's challenge? Anybody else? So we all feel we need the vote. Thank you very much, Ruth. So I know it's going to be painful, but I'm going to ask you to go on mute now, because your temptation to jump in when someone says something sometimes is quite. And what I'm going to ask everybody in the group, however you know, whatever your experience is, whatever your knowledge base is, no suggestion is a silly suggestion, because sometimes the most wacky ideas suddenly spark a creative, you know, something in us. So please, can you all now try and think of something? What would you recommend? What solutions would you do? What would you try differently or suggest for Ruth to try differently? Claire. Was Claire? Yes, who's got a hand up? Yeah. Sorry. Hi, Claire.
I was just going to ask if you had a shared.
Can you? Sorry, I can't hear you, Claire.
Sorry, can you hear me now?
There you go.
Yeah, sorry. I was going to ask, do you have a shared leadership council on the ward or shared governance council?
So that's still a reality question, is it? Is that another reality
Well,
question?
no. So what she could do is, if there isn't one, set one up. So then it's led by the team on the ward. So actually, you've got the leaders that are want to lead and want to, you know, develop that way, and will take people with them. So you almost put in that kind of responsibility and engaging somebody to take the lead with that, and maybe be able to come and help you sustain that because they're there all the time. So it's almost like transferring that over, that responsibility over.
Lovely, thank you very much. So that's about shared governance. I've captured that. And then Julie's suggestion, just so that we can all hear it out. Not sure how the beds are arranged, but could bays have weigh days with posters, etc., so patients will be expecting it? So it's actually about visionary displays of who needs weighing.
Love that.
Brilliant, thank you. And I'm just waiting. Julie's putting something else in the chat. Anybody else got any suggestions? However bizarre. Remember, there's no silly suggestion. I've also, before I go into Robbie, another suggestion is Weigh Wednesdays, something people can remember. So thinking of a, you know, I think there's that thing that if it's Wednesday, weigh, you know, that's a really good one. Weigh Wednesdays, that's a great idea. Robbie.
I wanted to sort of understand how often we kind
suggestion.
Yeah, so
I have to keep him in control. No questions, solutions.
I've got the mind of a butterfly, so I've got 1,001 ideas and thoughts. But I was just thinking about how we could potentially share the impact across teams and share the results. So there's an opportunity to really celebrate, because how often do we give feedback? So there's opportunity to share and celebrate, as well as provide an evidence base that could be shared. So there's opportunity to improve. How regularly do we do that? And then building on, I'm going to do two. Sorry, Lindsay.
That's fine. Great.
Once I start, I can't stop. Building on Julie's point, can't we really enable our patients? I don't like the word empower, but really put this back into the patient's hands and say, right, you can expect to be weighed on these things. If we don't do it, please remind us. So you really say to give the care aspect of this to the patient, so that they can hold us to account a little bit for their own weighing, is another thought.
Okay, thank you, Robin. Anybody else can just remember some of these things? I mean, I'm sure that Ruth thought of some of these before, but it's just reinforcing ideas that you may have tried elsewhere. Anything else that you think might be a solution? I mean, if you don't mind me making, oh, sorry, I'll go to you first. It's Darren.
Hi, could we bring the doctors on board with this to make it part of their daily round or weekly round to make suggestions about the benefits of being weighed more often? So if you brought them on board, then they could help the nurses do that. So if they say, can we weigh on Wednesday, can we have all patients weighed on Wednesday? Then if the doctors are on board with this, then the staff are more likely to be on board with this as well.
Okay. Thank you. I've captured that one, Darren. One of the ones I was going to suggest, Ruth, is having, you know, sort of like, I mean, I know you said you don't want to name and shame, but it is about, as Robbie said, to reinforce what Robbie said about celebrating. Actually, in the daily, if you had daily huddles, so the nurse in charge knew that one of the things was to say in the daily huddles or the regular huddles throughout the day, right, who's got anybody to weigh? Do you need it? You know, what are the barriers? What do we need to do to remind people? Julie, well, I can't.
Julie, you've got your hand up.
Oh, sorry, I missed that. Julie? Oh.
So building on the point that was just made around the doctors, one of the things that Ruth said was about the important link with medication. And so how have we shared the evidence around this? So the why really explains the why to win the hearts and minds. And could we potentially track through the measures the impact, the wider impact on patient safety, patient outcome, patient experience? Could we share those regularly? And you might get that buy-in that was mentioned from a medical perspective a bit more.
Thank you, Robbie. Fion's just put in the chat as well, present a positive case study to the team. And interestingly, I must be glass half empty this morning. I was almost going to suggest the exact opposite, that I think a positive case study is about really good, but actually maybe look at a story where a patient hadn't been weighed and their nutritional risk had been missed and the impact it had on that patient. So either way, I mean, go with the positive. We're all about fab and positive, but so, you know, patient stories are very powerful, aren't they? You know, that could be my mum, my sister, my uncle, my aunt, you know, that's how I, you know, use. So I think that's a really, really good idea, Fion. Thank you. Robbie, is that a legacy hand or a new hand?
That's a new hand.
New hand, good.
Just to say that I think that's an amazing point. So in terms of those individual stories and examples to bring it to life, because you need to communicate 7 times in 7 different ways, because people like to take in information. You know, I like pictures and stuff like this to bring it to life, and talking face to face. Other people will want more time to reflect on things and read things, etc. So think about that in your comms around how we communicate and share.
Yeah. And it's not a question as much. I should have done this in the reality, but how, you know, looking at keeping it at the forefront of everybody's mind, because it is about the sustainability here. What else could you do, or the ward manager to do, to weekly newsletters on compliance data, patient stories, just to keep it in everyone's mind, and asking the team, what else could we do? And I think that shared governance at the beginning that Claire was talking about it's really important. How can we ask the team how they can contribute to making sure they improve compliance? I can see Claire. I can see Claire's typing. But is there anybody else who'd like to make any suggestions?
I'll just speak rather than typing, if that's all right.
Yeah, go then.
Yeah, it was just around the equipment, really. So just thinking about what it's like on the ward. Actually, is there sufficient equipment? Are there sufficient scales? I know I used to work on the ward, and, you know, seated scales were difficult for patients that couldn't move. So actually, is there a barrier that could be overcome in terms of the actual equipment?
Thank you. Capture that one. Oh yeah, come on, Robbie.
Well, so why am I taking myself off? We have something in the hospital here at Harlow that we use, which is the 5 Ps. So think about patients, people, performance, places, the environment, and the pounds. So thinking holistically around this improvement, is there anything that we could do at any of those points to kind of bring it to life? And from that, building on that, if your divisions, for example, or your specialties have performance meetings with the executive team or anything like that, is there an opportunity that this is part of that agenda? So it's built into business as usual, and there's an item where you can say, right, weighing, and let's try and quantify the impact for patients, people, performance, places and pounds, so that it brings it alive across that kind of balanced scorecard, and brings it across the agenda of more executives, more different groups of staff. So it's not just on the shoulders of perhaps nursing.
Okay, thank you. Claire, are you typing again, or do you want to?
Yeah, I was just going to offer like a different solution in terms of like leadership development. So I'm new in post, and we're looking at a brand new set of leadership programs which are multidisciplinary. So it'd be nursing, midwifery and AHPs. But maybe there's some work. I really would like some outcomes from those programs. So whether they go away and do something around quality or whatever it is. So maybe there's a piece of work that we could do together that could link into some of the leadership programs that could then be taken back into practice to help overcome things like this in the clinical environment. So maybe there's a piece of work we could possibly do together.
Okay, Robbie?
I've got another one. Sorry, I'm going to shut up in a minute.
No, don't.
So a general one around, because we've struggled with this particular point, and Lindsay and I both love that cartoon. You know, the cartoon of someone pushing something, a bike or whatever, with square wheels, and they're saying, "I can't stop. I'm too busy." And there's someone behind them with a circular wheel going, "Just stop. I can help you with this." So are people too busy to improve? And one thing that we think about is how we function as teams. Because we all have got this guilt that we need to respond to firefighting in the NHS. We love firefighting in the NHS. We need to down tools, drop everything to help the greater cause, etc. But how can we work better as teams to say, right, you three firefight, protect me and so, because we are going to concentrate on improving things, so we build our way out of this and protect each other, work together in that way, building that capacity and give people permission to class the important as urgent.
I think Julie's typing. I'll wait for Julie's response. Julie, do you want to? Oh no, she's done it. Lovely. Oh,
where is the equipment?
No, I've done that. Patient held nutrition passport.
Oh, yeah.
So Julie's suggestion is having a patient held nutrition passport, which has weight and suggestions for the family, and obviously the patient would hold that.
Love that.
So that's a good idea. Thank you. So I have captured some notes, but I think, Ruth, you were busily scribbling down, weren't you, as well? Is there, and before we hand back to Ruth, is there anybody else who would like to contribute or would like to make any suggestions? That's wonderful. Right, so, oh, Fionn, I'll just wait for Fionn to put hers in because you don't want to miss it. It might be the gem that saves the day.
Typing from Somerset. Drum roll, please.
Bless her, don't put her under pressure. Fionn, no pressure.
Right, sorry. I don't know why it came up that I was typing.
Oh, okay. So, Ruth, would you like me to recap, or have you made enough notes, do you think?
Yeah, I've got notes.
Lovely. So obviously putting you on the spot a little bit, lots of suggestions there, and I felt really some amazing suggestions, and I'm sure some of them you've thought of yourself, but sometimes is it. So what resonated with you most? What were the things that sort of were like, whoa, I haven't thought of that?
Thank you, everybody. Yeah, some of the stuff we've tried, but what resonated most was turning it around so that it's the patient expectation. I think that's a good one. Clinicians on board, I agree with, and it's something I'm looking at in another work stream, so yes. How have we shared the evidence? So the why, that resonates. Case study, of course, patient experience is really emotive, isn't it?
Yeah.
Sorry, I think the weekly sort of updates, so weekly data updates maybe, and that's celebrating small wins, isn't it?
Yes, yeah.
And I think bringing it to a different forum, you know, when you talked about the meeting across the division, so I like that. And also with Claire about, you know, part of leadership development. I think that's a really important point, because I was a ward manager and nobody sort of showed me how to do it. You just learn on the job, and it's a really, all jobs are tough, but it's a really challenging job, and I think they need that support, and quality could be built into that, couldn't it? And the nutrition passport, yeah, those are all the biggies for me, I think.
Lovely, thank you. So I don't want to put you on the spot again, but what is the first thing that you would take away? What's your next step with this? How are you going to take this forward?
I think my next step is going back to how we shared the evidence. Mm-hmm. I think I'd start with that.
Okay.
And then I think I'd also do the weekly updates, but not just to the manager, to the team.
Yeah. Yeah. Celebrating it and sharing it. Fantastic. Yeah. Thank you.
Yeah.
So that brings your bump in the road, hopefully, to some solutions, and we'll be fascinated to hear the outcome and how it got on for you. How was that experience for you, Ruth?
Yeah, it's good because it's sort of because I presume it's a problem that a lot of people come across.
Sure.
So yeah, and it's good to get different ideas because some of them are things we've tried, and then the fresh eyes is always good. So yeah, it's good. It's helpful.
Thank you. And for the rest of the contributors, first of all, thank you so much, everybody, for contributing. And I'm sure, but how did you feel? How did you find the actual process? Were you quite comfortable with it? What would have made it better for you? Thank you, Claire.
First time I've done it over Teams, and I thought it worked really well, actually.
Good. It's so different, isn't it? It's so different. So it's challenging. So we're all developing new skills, aren't we, since Teams and everything. But thank you. So thank you very much, and thank you so much, Ruth, because I think going first is always the most tenuous. But hopefully you'll come away with some gems from that.
Thank you, everybody.
No, thank you. Lovely. So. Now you've seen how it worked for Ruth, is there anybody else that would like to volunteer to share a change? And it doesn't have to be in, obviously, Darren, I appreciate, and I'm looking at you because your face is right in front of me, sorry, but you're new to this team, but it might have been something you've tried to do in a previous job. But is there anybody else that has come across a big bump in the road when they're trying to introduce improvements or change? So, this is not a magic, we're not going to make anyone do it. So Vanda, as the facilitator for the group, how would you like to take the rest of this session forward? Because obviously we do rely on, and I appreciate, I'm not going to put anyone that we don't want to keep people hanging on if there's no further stories to share.
Well, I'm just trying to think of one that I could use for you, to be honest.
It's gone so smoothly.
We can talk about my role. My role is quite unique. So for many years I worked in the clinical area as a research nurse. I managed a team of research nurses, and as well as doing my clinical role, I also sort of promoted research and talked about research and wore the t-shirt about research. But this role I've been in for the past 3 years. I'm embedded within the quality team, but I'm now a nurse researcher. So I do my own research, and I'm developing as a researcher. As part of that, I'm doing my PhD, and I'm also a nurse educator. So I sort of had a blank canvas, and so when I came in post, I knew. From doing my own research in my master's, that people felt that research was, it's nice to do research, but it's not really an important part of our service. We're looking after patients. That's far more important than research. So I knew as part of my role, I needed to sort of embed that and start to talk about research in a different way and raise the profile of research. And so that's what I set out to do. So I managed to get in induction, in the induction programme to talk about research. I began to do bite-sized sessions of people, not just from nursing, but from midwifery, allied health professionals. So people could relate to different people actually who carry out research. It's not something that you just do to get a qualification, but it should be part of your practice. So learning is research orientated, because you have to find out things. So whatever role that you're in, we should connect to research. So I also developed a branding, so connect with research. So that was my brand, which I still promote today. So it's been quite tough, really, trying to be a one-man band. I had a remit of how to do stuff, but I wanted to do so much, and it was quite difficult. Had no budget, no team, no direction.
So what I'm hearing is if you're happy for us to expose, is your bump in the road the fact that you're a lone ranger almost?
Yeah, absolutely.
Yeah. So one man team. So is it all right then if we ask some more in-depth questions to try and get to reality
absolutely.
about what your barrier is. Thank you. So my first question is, how many research nurses are there in the organisation?
Well, there's quite a few research nurses, but research nurses do a different role. So it was part of promoting what they do and the multiple skills that research nurses have, because they are clinical nurse specialists in their own right. And people don't necessarily think that they are very multi-skilled and clinicians in their own right. So part of my role was to talk about that, because that is the group of colleagues that I came from. In my new role, I felt it was very important to talk about their role, but it's very different to a research nurse is very different to a nurse researcher. Because research nurses actually facilitate, they look after patients, they recruit, they scope, they horizon scan for new studies, and studies have already been developed. So it's usually clinicians, doctors who lead particularly randomised controlled trials. So that's what research nurses do. But lots of nurses are becoming principal investigators now, and doing their own nurse-led research by nurses who have developed research protocols.
So you said the barrier is sort of being a one-man band within the quality improvement team. So how would you know you've overcome this barrier? What would be your measure of success?
I think it's very difficult to measure success in the conventional term, because I can measure, and I do sort of look back over the year and say, well, I've done this amount of presentations, I've written this amount of papers, you can measure it in that context, but the real,
how would you know,
measure really is how people are relating to research, and that's what's important out there in the clinical area.
What's going to tell you that? What's going to tell you that people are relating to research? What are you going to look for?
I think people engaging with research at a more comprehensive level rather than superficially just for their qualification. So they're using research as a skill rather than a vehicle to get them a qualification. So if there's a problem, if there is a bump in the road, what have other people done? So the Fab Academy is such a great vehicle as a start to show people what's been done before. So you don't have to be at the top of your profession in research, professor, to actually connect with research. So connecting with research is about finding out what's been done before, why, how, who. So we're giving the right treatment to the right patient at the right time. So going back to Ruth's suggestion, what's been done before in this area of weighing patients? Why is weighing patients so important? So evidence-based practice, and that's what's important to me, that people out there in the clinical field don't just do things like robots, we've got to do this, but why do we have to do that? Why is weighing patients so important? Why is it best standard of care to weigh our patients? And there's a clear rationale why weighing patients who are poorly is so important.